it's about new drugs in thalassemia, and I tried, as I said, I've just returned from Vienna, and I tried to the best of my knowledge and capabilities, to adjust the talk to represent, or to present rather, some news on the novel treatments which has been presented at EHA. So the management, as you know, of thalassemia is optimized to each patient's clinical course and profile, and it's primarily focused on the improvement of anemia and the regulation of iron overload, but also its complications. So the quality of life of our patients is affected due to the lifelong need for chronic transfusions and iron chelation treatment, and the relevant complications. And allogeneic stem cell transplantation is a potential curative treatment for transfusion-dependent patients without iron-related complications, especially at a young age. However, and it's provided a standard of care in terms of curative options. However, it's not for everyone, and in all, our patients face many challenges and limitations when it comes to both curative as well as non-curative treatments. So a better understanding of the pathophysiology of thalassemia has led to an increase in the lifespan, and really paved the way for new therapeutic strategies. And gene therapy has advanced, and phase 2 clinical trials with the use of beta-globin insertion techniques and gene editing have been successfully completed, leading to approval for the use of the beta-globin insertion techniques in transfusion-dependent patients in some places in the world. And genetic and epigenetic manipulation of the gamma or beta globin gene have entered the clinical trial setting, and this is the gene editing CRISPR mainly option. And agents such as TGF, beta ligand traps, and pyruvate kinase activators, which reduce the ineffective erythropoiesis, are being also tested in clinical trials with indeed favorable results. One particular TGF beta ligand trap, the luspatercept, has been approved for use in adults with transfusion-dependent beta thalassemia, and we're going to talk about that in more detail in the next few slides. And the induction of fetal hemoglobin with the phosphodiesterase 9 inhibitor IMR687, which increased cyclic GMP, was in phase 2 clinical trials, but unfortunately those had to be recently interrupted or discontinued, not because of any adverse events, but because of lack of proved efficacy. Drugs which target this regulation of iron homeostasis, so for example hepcidin agonists or ferroportin inhibitors, are in trials too, so loads really happening. So we talked about that. So really there are 3 main groups in which the emergent treatments are categorized, and this is depending on the pathophysiology mechanism, of course, they target. So we have the correction of the globin chain imbalance by gene therapy and gene editing techniques. We have the agents which address ineffective erythropoiesis, so the activin receptor traps, pyruvate kinase agonists, JAK2 inhibitors, and we had the PDE9 inhibitor, which was interrupted, but I'm sure there's going to be more interest in looking into other molecules which can address ineffective erythropoiesis in this, following this pathway. Improving iron overload, this is where we have the mini-hepcidins, ferroportin inhibitors, and the TMPR SS6 agents. So it is remarkable, really, how in the last decade the interest in the unmet needs of thalassemia has completely changed, and there is now an increasing number, endless number of trials being designed and set up in this field. There is a large number of trials open already, looking at new treatments both in transfusion-dependent and non-transfusion-dependent thalassemia, as I said, targeting different pathophysiology mechanisms and across different phase stages. And you can see on this slide and the next one how the trials are across phase 1, 2, and 3. and majority of them commercial and multi-center. So talking about targeting ineffective erythropoiesis agents now, so the activin receptor ligand traps are the main ones. So they act as traps for the TGF beta ligand superfamily. So they inhibit signaling by binding ligands and sequestering them away essentially from their receptors. So they enhance therefore late stage erythropoiesis. Remember, EPO is an early stage erythropoiesis enhancer. This is a late stage one. So sotatercept was the first one to be developed and acts on late stage erythropoiesis as well to increase the release of mature erythrocytes into the circulation. And the luspatercept is a similar fusion protein, but does not bind with high affinity to activin A. So it's if you want, a cleaner product. So the potential positive impact of sotatercept in thalassemia was discovered really completely coincidentally when in a phase 1 clinical trial in postmenopausal females, it was seen to increase the hemoglobin level, the hematocrit levels, which was later shown with luspatercept too. But unlike sotatercept, increases in the bone mass density are not seen, and perhaps that is because luspatercept does not bind with high affinity to activin A. But this is how luspatercept was developed, really from the coincidental observation in the postmenopausal women with sotatercept that it actually increases the hemoglobin. So luspatercept, yes, finds only, so this is the phase 3, the BELIEVE trial looking at the luspatercept in TDT. So yes, binds only minimally to activin A, therefore lower off-target effects compared to the sotatercept, and that is why it was selected as opposed to the sotatercept to go into the phase 3 development. And the BELIEVE trial is a randomized double-blind placebo-controlled study in adult TDTs. Primary endpoint is equal or more than 33% reduction of the transfusion requirements from baseline, and 224 patients were randomized and then onto the IMP versus 112 to the placebo. So this is the design of the study. The age were 18 and above on regular transfusions, luspatercept randomization of 1 milligram per kilogram every 21 days, administered subcutaneously, titrated up to 1.25 mg per kg against the placebo, and then to the open label up to 5 years and post-treatment follow-up 3 years. So really those data which were published in the New England Journal of Medicine by Gabellini 2020 shows that luspatercept significantly reduces the red blood cell transfusion burden in patients with beta thalassemia, and a significantly greater proportion of luspatercept treated patients achieved clinically meaningful reductions in this burden of equally or more than 33% and more than 50%. So you can see here the graphs on the left side, about 20% achieved more than 33% reduction from week 37 to 48, and on the right hand side above about 10% more than 50% reduction in the same period of time. And also from the safety point of view, generally speaking, we can conclude from this data that luspatercept is generally safe and well tolerated in TDT with no particular toxicity, although one should be cautious about the risk of thrombosis when somebody is not monitored on luspatercept and not effectively and well transfused. So that is a problem that can develop potentially, but overall no safety concerns. So a biomarker analysis of patients on luspatercept in the BELIEVE study led to interesting findings presented by my colleague, a research fellow, postdoc, Maciej Gabowski, who's going to talk later about iron. So that was presented at ASH last year, and essentially reduction in the ferritin and hepcidin is consistent with the redistribution of iron from macrophages to hepatocytes in patients with TDT, and appears to be a mechanism of action of luspatercept in these TDT patients. So so this is basically what I just summarized. And so the luspatercept, now called Reblozyl, was FDA approved in November 2019 for the treatment of anemia in adult patients with beta thalassemia who require regular red cell transfusions, and was approved in EU in June 2020. What is happening in the rest of the world? So the BELIEVE trial, essentially, within the BELIEVE trial, more than 50% of patients are still on luspatercept treatment after 3 years. It achieved full reimbursement for beta thal and MDS in those countries listed there. So Germany, Belgium, Austria, Luxembourg. Italy is in the final stages of achieving reimbursement. There are interim patient access programs, so ahead of reimbursement in those other European countries listed there. And UK is awaiting for a NICE decision, so it's not NICE approved yet. NTDT data are a little bit behind the TDT process, and patients are still in the trials follow-up pending approval. So this is the NTDT luspatercept Beyond study. So it's a phase 2 double-blind randomized multicenter study in NTDT patients, randomization 2:1. Again, subcut every 3 weeks for 48 weeks, and primary endpoint is the increase of the hemoglobin by 1 or more grams per deciliter from baseline. And 145 patients were randomized, 96 received luspatercept, 49 received placebo. Again, very well tolerated, and those results were presented at last EHA by Ali Taher. And essentially what it shows here is that the primary endpoint was achieved with more than 1 gram per deciliter increase in of the hemoglobin in 77% of patients, with good correlation of the increase in the hemoglobin with the quality of life. So the NTDT Pro-TW is the first validated reported outcome tool for NTDT patients, and it has 2 domains, fatigue and shortness of breath. And here you can see on the left that the patients on luspatercept showed a good correlation of their increase of the hemoglobin against the quality of life. So just a clinical case to make it give it a little bit more meaning, really. So this is a UCH patient, 42 years of age, NTDT, baseline hemoglobin 52 grams per liter, never been on regular blood transfusions, splenectomized and cholecystectomized at the age of 14, mild diastolic dysfunction in keeping with anemia, recurrent gout. So over the last few years before we enrolled her into the clinical trial, she has becoming essentially, in a very obvious but sort of gradual way, more and more compromised from her hemoglobin. So with this increase of her diastolic dysfunction, increased episodes of gout, increased fatigue, and reduction of her performance status. So previously on X-ray for iron overload, osteoporosis, and on top of the sort of clinical deterioration, her hemoglobin was worsened as well with poor tolerance. So what was the discussion? The discussion was around with her as well as with the rest of the team, what to do next. I mean, should we start transfusions? But those would increase the rates of iron overload. It would increase the risk of alloimmunization. Remember, the longer you wait to start, or the older the NTDT patients are when they first start transfusions, the higher the risk of alloimmunization is. Or should we do something to reduce the ineffective erythropoiesis? So from the pharmacology point of view, so we thought about hydroxyurea, but we also thought about other approaches like involvement into, at that time it was just a sotatercept clinical trial available. Remember it was the first activin trap receptor which was studied in the clinical trial. So she was indeed enrolled in the sotatercept clinical trial in November 2012 at the age of 42, and she responded very well and remains transfusion independent, and increased the hemoglobin from about 50 to about 80 grams per liter. And the results from the Beyond study suggest that luspatercept now, and she actually switched to luspatercept. Why that is? Because the sotatercept clinical trials have now stopped, but those patients who were still in the sotatercept trials and had benefit, it would have been, of course, unethical to stop it, and therefore we switched them through a special access agreement here at UCH to luspatercept standard of care. So she continues to do relatively well. I mean, she has other things developed that we're investigating, but from the hemoglobin point of view, she responds well on the luspatercept. And really, the results from the Beyond study suggest that this drug, the luspatercept, will be as well tolerated and effective as the sotatercept. Now, this is the updated EHA slide that I've just put in a couple of minutes ago. So you can see here that those were 4 late-breaking abstracts presented yesterday, and the first in thalassemia. And the first one is by Maria Capellini, Italy, who's published a lot on luspatercept, especially in NTDT, but also in TDT. So the first abstract reads longer-term analysis of efficacy of luspatercept versus placebo in patients with TDT enrolled in the BELIEVE study. And these are this is the summary. So so we have more data basically published now on it. So continued treatment with luspatercept resulted in more patients experiencing reduced transfusion burden and longer duration of response compared with previous data cuts. The time between transfusions increased compared with the baseline for more than 50% of the responders. More patients are experiencing transfusion independence for more than 8 weeks, and a potential decreasing in the trend in the liver iron content, but the latter analysis is still ongoing. So overall, this extended data presented yesterday suggests that patients continue to benefit from longer-term luspatercept treatment with no overt safety issues. Now, other agents which tackle the ineffective erythropoiesis, so the pyruvate kinase agonists, so mitapivat and etavopivat. So they decrease the 2,3 DPG levels and increase the ATP in the red blood cells. The mitapivat is a bit ahead from the etavopivat. The trial started first looking at this molecule. And they're produced by 2 different companies. So the mitapivat is already, but it hasn't reached EMA approval yet, as far as I know. And the safety and efficacy in thalassemia is under investigation in clinical trials as we speak. And at ASH, so only a few months ago, so 6 months ago, there was a presentation about the long-term efficacy and safety of this drug in adults with NTDT alpha or beta thalassemia. So these were the results from the phase 2 open-label multi-center study in these patients, which essentially show that 80% of the patients included in the trial met the primary endpoint of the hemoglobin response, defined as equal or more than 1 gram per deciliter increase in the hemoglobin. They improved hemolysis and erythropoiesis, looking at specific parameters, and overall no safety issues. So in summary, these data support that mitapivat, through activation of the pyruvate kinase in the red blood cells, may represent indeed a novel therapeutic option for these patients with alpha or beta thalassemia. And So based on those results, 2 phase 3 randomized controlled trials were initiated, and the Energize and the Energize T. So we have those open at UCH if you have patients interested, and you have no sites nearby which are open for this, so you can always send me an email. So the Energize is a placebo-controlled trial to look at it in non-transfusion dependent alpha or beta thalassemia, and the Energize T, same drug, same doses, and placebo-controlled again in TDT patients, in transfusion-dependent patients. And just as a point of note here, these are really important studies because at the moment, so far, we really don't have much in HBH disease patients. So for the first time, really, we have clinical trials open which look at drugs in HBH disease. Very important. So this is another new slide that I've just put in, again, fresh from press, presented in EHA by Kevin Kuo, so Toronto team. So really this slide shows long-term efficacy and safety data of this mitapivat in NTDT. And essentially overall they show a favorable efficacy safety profile, consistent and with and durable essentially improvement of the hemoglobin and hemolytic markers, as well as improvement of ineffective erythropoiesis with this drug up to 72 weeks of treatment. So the other PK agonist in clinical trials is the etavopivat. So same mechanism of action, so once a day drug, and the phase 1 experience seems to be promising. So healthy volunteers, 150 to 200 milligrams twice daily, and also in patients with sickle cell disease, not regularly transfused. So this is where the phase 1 experience is collected from. Given up to 12 weeks, was well tolerated and demonstrated a favorable tolerability profile. It decreased hemolysis and significantly increased the retinal lifespan, as well as improved hematology markers, so hemolytic markers and markers of retinal health. So now based on those phase 1 results, it entered or is entering rather the phase 2-3 clinical trials in patients with transfusion dependent sickle cell disease. So that's cohort A. Cohort B is the TDT patients, and cohort C is the TDT patients. So again, this is a study that I'm opening at UCH. So it would be interesting to to look at this molecule as well. And there are some differences. There are some differences between mitapivat and etavopivat in terms of how they work. They're not exactly identical, so I am expecting some clinical differences as well. This is the IMR 687, which unfortunately looked to be a good molecule. It's very selective PDE9 inhibitor, which increased the fetal. The hypothesis was that this would increase the fetal hemoglobin, but overall it didn't show significant efficacy. Therefore, it was stopped. The thalidomide now. Why do I have this slide? Because there is an increasing. So over the years, in order to correct the imbalance basically between the alpha and the non-alpha chains of the hemoglobin, other agents which promote the production of gamma chains, apart from hydroxycarbamide and the phosphodiesterase inhibitors such as 5-azacitidine, short chain fatty acids, and thalidomide have been used in thalassemia patients and presented partial responses without really though long-term favorable outcomes. But recently the thalidomide has been used again, and this is a with some promising results. So it's just you know, something to keep in mind, especially if we're very stuck and cannot go further with particularly complex patients. So this is a small study that I found presented relatively recently, published relatively recently. It was a prospective single-center open-label study in the pediatric population, 12 to 18, thalidomide for 6 months, 2 to 3 milligrams per kilogram per day, and it resulted in moderate to major responses in the majority of the children with TDT, with satisfactory adverse effect profile. But what I'm worried about is the risk of thrombosis, really. So we just have to be very careful. So the JAK2 inhibitor, the ruxolitinib, it regulates hemoglobin gene expression. It was looked at in the TRUTH study, so it was a phase 2A trial in 30 TDT patients with splenomegaly. It was given for 30 weeks. It did show some improvement of the pre-transfusion hemoglobin and related reduction in transfusion needs, but not a lot. The effect was limited, and therefore it was decided that no further phase 3 studies were going to be planned. Now, looking at how new treatments aim at sort of, you know, cure the disease. Now, the next few slides will concentrate on the correction of the globin chain imbalance, and so there have been significant improvements in the technique of, you know, hematopoietic stem cell transplantation, of course, as you know, with a focus on the improvement of the conditioning regime and the donor selection. But gene therapy is becoming more trendy as well. Gene therapy by autologous transplantation of genetically manipulated hematopoietic stem cells looks to be a very promising curative in patients with thalassemia. And throughout the last decade, several gene transfer protocols have been really intensively explored. And among them, the lentivirus vectors have been used in thalassemic mouse models and in erythroid stem cells from thalassemic patients, as well as in actual patients. And so cellular therapies for thalassemia, here this publication in the New England Journal of Medicine by the Thompson USA team. This is looking at the gene therapy with the by ex vivo lentiviral transfer of a therapeutic beta globin gene to hematopoietic stem cells, and these are the data summarizing the results of 2 big trials, 22 patients in total, and essentially after that publication, which showed promising results, the long-term follow-up study data were presented as well at ASH last year, which was the data on 63 patients in total across different age groups, beta 0, and non-beta 0 genotypes, 57 with 2 years follow-up, 20 patients with 5 years follow-up, and 11 patients at least 6 years follow-up. Approach. The average hemoglobin of those who achieved transfusion independence was 10.3 grams per liter in the phase 1-2 studies and 11.6 in the phase 3 studies. And there were no deaths, no vector-derived replication competent lentivirus, no events of insertional oncogenesis or malignancies, and no drug-related AEs. It's FDA. It's been given FDA-granted orphan drug status and EMA EU approval in 2019. It's not NICE approved. Now, what about the CRISP-R study now? So the fetal hemoglobin elevation, as you know, is associated with improved outcomes in these patients, and the This is the CTX001 product, which is it's been studied. So this is a CRISPR-Cas9 editing, yes, of the BCL11 gene, which leads to the fetal hemoglobin by essentially editing by ex vivo CRISPR-Cas9 gene editing at the erythroid enhancer region of this gene, of the BCL11A gene in the autologous CD34 hematopoietic stem cells. Due to the promising preclinical results, this CLIMB-111 trial was designed. It was a phase 1/2 international multicenter trial, age group 12 to 35 years in TDT patients, and the first results were presented by Locatelli's team at EHA last year. And at that time, there were 15 patients with more than 3 months of follow-up after this gene editing treatment. And essentially, overall, he showed that the safety profile is generally consistent with myeloablation and autologous stem cell transplantation, and that this treatment led to increase total hemoglobin and fetal hemoglobin, which occurred early and was maintained over time. And also a pancellular expression of the fetal hemoglobin, which again was maintained. So all those 15 patients were transfusion-free at the time of the analysis, with up to 26.2 months of total follow-up. And again, this is a slide that I've just created with Locatelli's new data presented yesterday. The title of his presentation and the abstract you can easily get hold of online: efficacy and safety of a single dose of CTX001 for transfusion-dependent beta thalassemia and sickle cell disease. So he presented both data in both cohorts, but I'm going to concentrate on thalassemia here because this is our topic. So 44 patients in total, so not 15, but 44 until now, so more patients. Age group 12 to 35, mean age 21 years of age. So 26 out of the 44 TDT patients had beta 0 or a beta 0 like genotype, so severe genotypes. All patients engrafted neutrophils and platelets. The median time to neutrophil and platelet engraftment was 29 and 43 days respectively. 42 out of 44 stopped red cell transfusions whatsoever altogether. 2 patients had not yet stopped transfusions, but about between 75 and 89% reductions in the transfusion volume were observed. Yes, and essentially no deaths, discontinuations, or malignancies. So to conclude, the safety profile is generally consistent with that of myeloablation and autologous transplant. That all patients demonstrated clinically meaningful increases in the total hemoglobin and fetal hemoglobin, with high levels of BCL11A edited alleles in the CD34 bone marrow cells. So yes, we're watching the space. It seems that it could be a promising curative option. Now talking about modulating iron metabolism, and we are reaching the end. I'm not sure how I'm doing with the time, but you can stop me anytime, please, if I'm overrunning. So the SLN124, it reduces serum iron levels and balances tissue iron distribution in mice with beta thalassemia by inhibition of the expression of the TMPRSS6 gene in the liver, and therefore it increases the hepcidin and it improves anemia, reduces ineffective erythropoiesis, splenomegaly, and iron overload. It was granted orphan drug designation by the Committee for Orphan Medicinal Products of EMA. And the results of the Gemini phase 1 randomized double-blind placebo-controlled study looking at this molecule in 24 healthy volunteers was presented at ASH last year. Mean age was 31 years of age. Good tolerance, no safety issues, plasma hepcidin levels were increased, serum iron was reduced, and the Gemini 2 trial is currently recruiting and will evaluate single and multiple doses of the SLN124 in patients with thalassemia, but also in MDS. So, to conclude, we now all live in a new era of novel therapies beyond transfusion and iron chelation. And we're really excited to be part of this new era. This is when the networking is very important, and this is why I'm very pleased and honored to be teaching today at your network educational group, because really there will be patients who will not have access to all these trials and or even to these treatments, and it's important to, by talking to each other and by educating each other, to make this as possible as accessible as possible to all patients. So the aim of everything or anything we do really in terms of designing a clinical trial or enrolling our patients in a clinical trial or recommending standard of care treatments continue, of course, to improve the outcomes and quality of life. It's about quality of life as well. The activin receptor ligand trap modules are so far the most promising and the most ahead of others molecules in terms of treating the disease, with significant improvement in hemoglobin and transfusion requirements and a good safety profile. Yes, and another important to conclude message is that ultimately long-term head-to-head and comparison trials using these novel therapies is necessary for the future to determine the optimal use of these novel therapies, and those novel therapies will probably be used synergistically or additively rather than monotherapy. But of course, these are aspects that we should be aiming to look at in the context of clinical trials as we understand more about these novel agents. And remember, no single treatment is going to be ticking all the boxes and is going to be applicable to all patients, and the treatment has to be tailored according to the individual patient characteristics. I'm going to stop here and thank you very, very much.